also going to put some notes in the chat, housekeeping notes. So yes, thank you, Maria. After a false start there, yes, you may carry on. Thank you.
Thank you for funding this work and inviting us to present the results of this of the a number of workshops that we did. You mean using nominal group discussion to understand how to improve patient safety and the well-being of carers by involving carers a bit more on the transitions process from mental health hospitals to the community. Well, I'm a senior lecturer at the Centre for Primary Care and Health Services Research at the University of Manchester, and Natasha is a research fellow funded by the NHR School for Primary Care Research, as well as the three-school collaboration, and undertakes a study on that space, but with a focus on patients. So we use these funds to understand how we can best support carers as well in this difficult process of transition from inpatient mental health settings to the community. Next slide, please. Well, transitions of care is the movement of a patient from one setting to another. Obviously, there are many different definitions, but this one is really simple and explains in a lay way what the transition means. On the other side, transitional care is a set of actions designed to ensure the coordination and continuity of healthcare as patients transfer between different locations or different levels of care within the same location. So transitional care can happen, can mean the point of care within the same setting, within different settings. Sorry, so transition from primary care to special care. It can also mean transition between settings. It can mean across different health states, for example, curative to palliative care. It can also mean transitions between the providers as well. So it can be in the same setting but involve different providers, and this is a transition of care as well. Natasha, could you please next? Well, the transition from hospital to community, specifically in primary care, is often described as a vulnerable pitch point in the patient journey associated with numerous harms. Next slide. So what we have done lots of work in the past 5 years to understand how to support mainly patients on that space. And we have worked, of course, with different stakeholders, including carers as well. But we focus more about how we improve the process for patients. And we also consider the input of carers, but we haven't specifically done any work which is purely focused on how to better engage carers and how to improve their well-being as well. So in terms of the patient perspective, we have done several interviews. We have done a couple of systematic reviews so far. We've done a random consensus meeting to discuss and adapt the patient care bundle for improving the discharge process and planning of patients from inpatient mental health care settings to the community. So we've done lots of work for improving the transitions of care for patients, and we involve carers, but we haven't specifically focused on understanding a bit more the perspective of carers and how to support them. Next slide, please. These are some of our publications in the field. Next slide. So this is based on this work that we have done. We have took the care bundle, the safer patient flow bundle developed by the NHS Improvement, and we have adapted those criteria for inpatient mental health care settings. Next slide. And we have come up with an intervention that I will kind of explain in this slide. So we agreed that discharge should be done in a more like in a standardized way using a best practice criteria, and start as soon as in the admission, and start by introducing a patient written plan, capturing information, social information as well, and then we thought that regular reviews of those documents and the processes is really important, like weekly reviews. And towards discharge, it is important that an appropriate housing is confirmed, as well as patients take their appropriate medication, and they also take with them a patient written discharge summary. Well, I'm discussing this topic because throughout these stages, patients are having a greater input in our work compared to what was proposed before. So when we say patient written discharge plan, we actually encourage clinicians to also discuss with carers and co-write with carers the patient written discharge plan. So we have done a lot of work trying to engage more carers, but we still thought that we need to do a bit more and very, very dedicated piece of work around carers of people with mental health conditions who are being discharged from hospitals to the community. Next slide. Yes, I mean, the interventions I have presented before involves a number of introducing a number of new documents to better capture the patient and the carer perspective, social information capture, and also we have included a series of videos and manuals to improve to implement it in at least one inpatient ward. Next slide. And this is how our current feasibility study looks like. And this is the background basically about why we actually thought that they're the best place to actually think a bit more about how to engage, to involve patient carers more in the transition phase, and how we can even improve this intervention by greater care involvement, as well as understanding what are their priorities for safety, and how we can also help them maintain their well-being. Next slide, please. So one key question that underpinned our work, funded by the 3 schools, were like, are carers of people with mental health conditions and underrepresented group in research who experience a hidden significant burden? Well, the quick answer is yes, and the main reason is that usually they care for carers of people with mental health conditions. They're not always seen as carers in the community because there is no obvious disability, and they themselves might not recognize as being carers. They might provide a lot of practical and emotional support, but they don't really acknowledge themselves as carers, even though they shouldn't. They should. Again, next slide. So the facts are that carers of people with mental illness may face distinct challenges, as we said, including navigating fragmented and health and social services during discharge from mental health hospitals, and they don't always. The process of care is really complex. They don't recognize themselves as carers. They might not get enough information and support from staff as well. Despite this, currently there are very limited examples of interventions that support carers of people with mental illness in improving patient safety during transitions of care. And this is not in line with evidence, which shows that people with mental health conditions who have a carer and is really informed, they actually have better outcomes of care, because one of the key facts in the literature is that patients after being discharged are particularly vulnerable, especially the first 3 months. There is high likelihood of readmission, suicide. So it's really, really important to try to support carers of people with mental health conditions at that specific time point. So we actually in this study we aim to identify problems and solutions to inform future carer-led discharge interventions, which is imperative for ensuring both patient safety as well as the well-being of carers themselves. Next slide. So what we did is we did a nominal group discussion. A nominal group discussion combines both qualitative and quantitative data collection methods and has four distinct phases. The initial phase is problem identification, then solution generation, decision making, and prioritization. The aim of the nominal group discussion technique was to combine expertise from different stakeholder groups and to identify problems and generate solutions for carer-led interventions to improve discharge from mental health hospitals in the community. And we particularly involved patients themselves, carers, academics with experience in that field, including primary care, secondary care, and public health. This was really important because we're talking about transitions and there are many different sort of services involved. So we endeavored to include expertise from different points of care. Next slide. There were lots of solutions that were generated by the group, and broadly they were categorized into four key themes. The first key theme was care involvement and improving care experience. The second was around policy systems and improvement. The fourth was patient well-being and education, as well as care and wellness and education. Next slide. Well, specifically in terms of what each of the themes mean is that for care involvement and improving care experience, one of the key solutions that were proposed were having a dedicated family liaison worker, which was considered highly valuable and also probably feasible as well. In terms of policy and systems improvement, the main suggestion there was enabling carers to better understand the coordination of care. In terms of patient well-being and education, the panel suggested adapting and implementing existing approaches to help implement the patient care plan. And in terms of care and wellness and education, the main view of the panel was we need more peer and social support interventions for carers. Next, please. And that was the first, let's say, the top solution. The second top solution was for care involvement and improvement experience was to support planning with care admission. For the policy systems and improvement, the second most common solution was more joined up approaches to working between services. And in terms of patient well-being and education, we also talked about education of patient illness as well, a bit more specifically, so that the patient and the carer both know about what the illness illness means for the patient in terms of also practical perspective. And in terms of care, wellness, and education, we also talked about care education about patient illness. So this solution is actually aligns with both themes, that we need a better understanding from the patients, and carers need to have a better understanding of what the illness means and what they are going to expect in the future. And yes, next. So in this study involving a diverse stakeholder group, we identified many patient safety concerns and care well-being risks during care transitions from inpatient mental health hospitals to the community. These include lack of information and support, distress, and isolation. Multiple solutions were generated based on the collective knowledge of the diverse stakeholder group as well. So we had it was really beneficial because we brought very multidisciplinary lengths within the study, and we actually were able to pick both the problems, but also identify some solutions, and some of them were relatively feasible, which means provide a very good basis to support future funding applications for developing and applying interventions in this context. Next slide. So, as a general discussion about what our study has found is that our findings are consistent with previous research, which highlighted that carers are concerned of their own mental well-being and patient safety during this difficult time. So it's the findings of the nominal group discussion showed that patient safety is a key concern that carers have, and they also are really concerned about their own well-being, which has not received as much attention before. Evidence also suggests that interventions involving carers have improved the experience of caring and the quality of life among people with severe mental illness and reduced the psychological distress of carers. And that intervention components for carers should be considered as part of integrated services for people with severe mental health problems. So our work is in line with evidence which almost universally suggests that involving carers is beneficial, but there should be a right context and framework for really educating and understanding carers and providing the right support as well, because sometimes passing the responsibility only might not be entirely very helpful approach, especially because this is such a hard time for carers as well. So a right framework needs to be developed around how carers can be involved and can be supported in the process. So, as a concluding, let's say, statement, as a concluding, we actually going to play a video which shows what we found as part of the workshop, and we'll explain in lay terms our findings, and we are really proud of it as well. Yes, Natasha.
More than 1.5 million people provide care for someone with a mental health problem. They provide crucial, unpaid help to friends and family members. To their loved ones, these carers provide vital emotional support, encouragement, practical help, and advocacy. Researchers at the University of Manchester held a workshop that brought together patients and carers to meet with professionals and academics from primary care, mental health, social care, and public health. Together, they discussed and co-designed potential carer-led interventions to safely support people after they are discharged from hospital. They also discussed and co-produced interventions to support carers and their well-being during these challenging times. Creating carer-led interventions is so important, as many carers themselves and people around them don't recognise the work that they are doing for their loved ones, as mental health problems are not seen. The work of carers of people with mental health problems can become hidden, and they therefore are less likely to access or receive much needed support than carers of people with visible problems. Carers of people with mental health problems desperately need support when their loved one leaves hospital and returns home. Someone's transition from hospital to home is often described as feeling chaotic. There's a risk of loneliness, self-harm, medication issues, suicide, and homelessness. Support is vital to all carers for a number of reasons, which include their concerns about the safety of the people they care for. Also, there may be fear around the stigma of caring for someone with a recognised mental health problem. Carers often experience symptoms of psychological distress, including anxiety and depression, particularly when the person in their care is young. To compensate, there may be an increased risk of making unhealthy lifestyle choices or failing to meet their own health needs. Therefore, supporting carers during transitions of care is vital for the safety of patients and their own well-being. The workshop held by researchers highlighted 19 safety concerns patients and carers face after hospital discharge. These include the challenges and emotional impact of navigating the discharge process, the insufficient coordination with primary care and wider community services, and the lack of access to these services where they do exist. These concerns create a gap in the immediate support that's available to carers during a patient's recovery. As a result of this gap, there's a risk a patient's health will deteriorate as they wait for support. This can increase the risk of carers feeling guilty or helpless and place a strain on their own mental health and well-being, relationships and work-life balance. At worst, carers can feel isolated and even be at risk of self-harm or suicide. To address these concerns, the workshop developed a series of solutions. The top 4 were appointing a dedicated family liaison worker, help for patients and carers to plan their needs, having a tailored peer or social support service for carers, and provide clearer guidance to help carers navigate and coordinate care. Everyone in the workshop agreed that these are realistic, possible solutions, but clear policies and financial investment are needed to make them a reality for all carers.
Well, thank you very much. I will be happy to answer any question if people, myself and Natasha as well, if any of the participants have any questions.
Thanks so much, Maria and Natasha. I know you prepared the slides. That was just fantastic. And I think it's such an important group that, you know, and I'm always saying about how people with severe mental illness are so overlooked. But then the carers of people with severe mental illness are really overlooked. And yeah, can face lots of issues, that they really have to contend with. I always have lots of questions, but I'm going to open it up to the floor first. So does anybody want to make a comment or ask a question, make an observation? Everybody's been very shy today, obviously. Oh, hi, great.
I wasn't going to say anything, just I was going to wait for you to. I mean, thank you. That was really interesting. I just wondered if I met, and it's not a question, just a comment really, how you think the use of nominal thingy technique was helpful in in actually getting to where you were. So, to what extent do you think that helped to frame, you know, your work really? Nominal group technique, is that right? Is that what it was? Yeah.
It provides a framework for people for voting, for having specific items that people can see, and also stages as well about how it has been about identifying problems, generating solutions, and then reaching a consensus with voting. So it did help a lot, because if you just had just a workshop without any framework, it is hard to keep it within the timelines and within target as well, because people tend to speak with for other things that they don't focus as much on the problem that you really want to solve. So I think it was really useful for that purpose, for framing it, and also for making sure that the focus is where we actually want it to be. I don't know whether Natasha has any additional points.
Yeah, I was just going to echo that really. I think I've done lots of different workshops that have been a similar amount of time to that workshop that was, say, 2 hours. And you can't really get down to identifying the problems and what the solutions are, and then getting everybody's opinion on them solutions as well. With the ranking exercise, it enables everybody's voice to be heard, rather than otherwise you can have 1 or 2 people who sort of dominate the conversation and you end up choosing a solution that suits them. And particularly when you've got all the different groups together, like the carers and the professionals, it enables everybody's voice to come through in the ranking exercise. So I definitely recommend that in terms of like when you've got a specific focus, which is to identify the problems and identify solutions.
And there is also an added benefit to that, because I mean, it's a scientific method. It's not it's just involvement and engagement of stakeholders, and we have received university ethics for it as well, and we are going to publish it, so it's going to be published outputs out of this.
Fantastic. Can I just, because I think another issue around, you know, if you're doing work with and about carers is you know, are there logistical issues in terms of getting carers to participate in research and also to get involved in research, given that they probably have multiple commitments, including caring for, you know, their loved one. Just wondered if you wanted to say something about that and perhaps how you overcome it.
I mean, well, obviously you have to present the case about why this is going to be useful for carers and the people they care for. So we will need to have a very good justification about why this research is actually really important, and this work is really important, and their involvement matters. And I would say also it is important to make sure that we reimburse participants as well, the carers that participate, and trying to make the workshop also relatively short, not too long, because they might have or arrange it in a suitable time that they can make it. And on the positive note, I would say, because they're an overlooked group, and they're really keen to go to speak about their needs, because not a lot of research really asks them about their needs. Usually they don't get much attention unless they just talk about patients, which they still like to do. But it is important that we have this element about how they cope with it, because with some of the carers really face significant problems afterwards with depression, anxiety. So it's something that needs to receive more attention.
Absolutely.
Just to echo that, so the reason I sort of came up with this idea is because I was in the build up to all of the safer work, I was constantly talking to carers, and the message that kept coming through was always like, sort of, what about us? And then I presented my safer research about improving patient safety and patient experience to the carer groups, and all the time at the end of the groups when I was asking for questions, all of the different groups were like, well, what about us? You need to do intervention for us. So the idea to even put in for this funding sort of came from carers themselves, really, at different times when I've engaged with them. So there's definitely that need, and that's why they were more than happy. The same sort of people I then went back to and said, look, we've got this funding to do this, so they were more than happy to participate. The idea came from them in essence.
Yeah, which is another good reason to, you know, do research on topics that are suggested by members of the public, because then they do actually want to get involved. That is the way to involve them. I've seen that there's another hand up. I can't see the name of the person though.
Yeah, Sue.
Sue, thank you.
Hi. Yeah, thanks so much, Maria and Natasha, for a really interesting presentation. Really interesting. I sort of my work is around people with dementia, and I was just thinking about transitions of care. It's really big, I guess, all sorts of transitions for people living with dementia. And I was wondering what you think of application towards family carers, people living with dementia, whether any work's been done, or I don't know what your thoughts are, really.
I will pass this to Natasha, because she's doing a study specifically for adapting the initial intervention that I mentioned for people with dementia. So yeah, Natasha.
Yeah, so we got some additional funding separate to this to adapt the Safer Mental Health Bundle, which we've already discussed, to make it dementia friendly. So we've got the patient written discharge plan at the moment, which is it's been co-designed, so all the words in there have come from patients. They've been sort of accepted by patients and stuff, but because it's about 5 pages long, it's quite small font, and obviously for people being discharged from mental health services, there's lots of older adults with dementia in mental health services, so we've had to exclude from the current feasibility study. So we got the funding to develop it to make it dementia friendly. So we're doing some workshops at the moment later this month. The first one is going to be with professionals to try. We're going to work with a graphic designer as well to try and turn it into images, so that the images will guide them conversations. We'll obviously use all the Alzheimer's Society ideas in terms of font and different things like that. And then we're doing parallel patient and carer workshops and professional workshops with people who've done this sort of work before and used graphic design as a way of doing it. So I don't know if that's something you're all the professionals.
Yeah.
What I want to add is that for this specific group, for people with carers of people with dementia and mental health problems, I mean, it's basically it's more imperative to actually work more with patients, because more with the carers, sorry, because obviously it is the main engagement, the main group that we engage, and in some cases they work we try to find ways to actually to either work with both the carer and the patient, but when the patient is not in a condition to really, have lots of input, this is the carer is our main point of contact. So it's really important within this group. I would say carers of people with dementia is perhaps and have an extra level of complexity as well as needs for further support.
Yeah. Oh, thanks very much. Yeah, really interesting. Thanks.
Thank you. That was a really good question. I think it's really interesting to look at how things can be transferred across different populations, if you like. So yeah, I'd be really interested. And I don't know if you're aware of the dementia programme, which is the equivalent programme to this, but for dementia.
That's what it was too, yeah. That's what it was funded through, the career development.
Okay, yeah.
Dementia, yeah.
Fantastic, yeah. You do know. Probably much more than I do. Are there any other questions or comments for Maria and Natasha? I did post the links to the papers that you mentioned in your talk. I hope they were the right links, so that people can access those afterwards. Can you tell me how much were carers involved in? So you had the 4 themes originally. Were carers involved? So I know they were participants in the workshops, but were they involved as Maria said, that you had ethics for that, and that was about participation in a research process as such. But were they also involved in? I mean, I think you said in your presentation that it was co-produced. So did they have a role in deciding what those 4 themes were going to be, for example?
So those 4 themes came out in the workshop. So we had no
I see.
themes in the workshop. We then had so many that when we were asking them to rank them, they were finding it impossible to rank like 30 items. So between us all in the workshop, we decided on them 4 themes. So that was co-produced with the carers. But up to this date, with the Safer Mental Health Group, we've got lots of different carers involved in like PPI workshops, and we'd ran the idea of the workshops past them in PPI groups that are ran for Safer.
And so this is a highly personal question now about how they found the ranking. I know you said it was difficult because there were so many items, because I'm about to submit a bid for some funding to do something similar. So I'm just contemplating how difficult it's going to be. Do people get on board with it okay in those workshops?
They actually produced more solutions, more problems and solutions than we thought. This was the only issue, that we're expecting to be, a shorter number of problems, shorter number of solutions. And actually, they did produce quite a lot, so it worked well. Yeah. I would just try to keep it focused, and perhaps discuss a bit more each of the problems and solutions that come up, because we then had a very large list, which was manageable in the end. But sometimes it's better if you produce fewer but more justified, let's say, solutions.
Yeah. So it's more meat on them, kind of thing. Yeah. Does anyone else have a question come to mind that they would like to ask about the project or other work that Maria and Natasha are doing? Any comments? Oh, yes, Alice is involved in this bid with me. So we're both listening very keenly to your advice.
You could always use that as a second step as well. If you do like generate a list of solutions that are too long, we sort of had to do that to make it easier for people, because it's quite hard to something that's about patient safety and something that's about carer wellbeing, it's quite hard to then rank the two unless you decide that one thing's more important than the other. So that's why we tried to see what the four things the items that they generated could then easily be ranked within them four things that focus on the carer wellbeing, the patient wellbeing, the systems, or I can't remember what the other one was, but they sort of naturally fell into them groups, so it's easier to rank within them groups. Otherwise, you've got to decide that carer wellbeing is more important than patient wellbeing to rank them ones higher.
I think that's that's my concern, is that everything will be, well, highly scored. Let's say everything's important, so it's how to, you know, separate the wood from the trees, I guess.
I would focus also on feasibility. You look at how important they are, but also you look at how feasible some of the solutions might be, and that's then how you prioritize perhaps the top ones. It's a combination of importance and feasibility.
Sure. Yeah.
So
sorry, go on. Sorry, Natasha.
We presented them two separately, the feasibility and the acceptability, so you can see which ones were most important, but then which ones were most feasible within whatever restrictions you've got. So we had two separate lists, and then we had an overall list as well when we added the feasibility and the acceptability scores.
Yeah. Well, this is very helpful advice for my bid that's going in on Wednesday. Did you have another question?
Sorry, no, I was just listening. So about the feasibility versus acceptability, and just reflecting. So we did.
I said feasibility. Usually, feasibility is used in the context of nominal, in the context of RAND, UCLA. A consensus method for nominal group technique is better called acceptability. So it's importance and acceptability.
Yeah. I guess I was thinking we did something similar in a different, very different context, and actually feasibility depends on who you ask. I was just sort of thinking, you know, whether the carers think it's so yeah. I suppose we got very different answers when we asked about feasibility from different groups of participants, and I just to comment that I think, you know, then how do you weigh up you know, from the different perspectives, has got another whole discussion around it. So yeah, anyway, but just an observation really, that I think that's a really good idea, but I think that the more dimensions you add to asking about, and if you've got different groups, you do tend to get very different perspectives.
Yeah. Absolutely.
Yes, absolutely. There is no perfect method, actually. This was an initial step. I guess if you finally decide which solution, which solution you prioritize and turn it into intervention, you will need to get lots of additional workshops with each of the solutions, discuss it with different groups.
Yes.
And then have a final. Make a final decision where you're going to invest the funds. But this was an initial prioritization, let's say, exercise to understand what might be important.
But I think it's so valuable to have those discussions, isn't it? And as you say, carers really want to have that input and to, you know, to be part of setting those priorities and actually telling you what their priorities are, what's on their agenda. So yeah, absolutely. I think for me, I think that's one of the most important parts of the process is, you know, valuing their input, but also understanding and perhaps revealing priorities and things that are on their agenda that haven't really been considered before, that aren't on, you know, because from a professional perspective or even a patient perspective, because patient and carers interests sometimes aren't necessarily aligned either. So yeah, I was going to say something else. Oh, I know. I was going to ask, are you going to be at the Three Schools Showcase event next week?
Kiel.
Is it? Yes, at Kiel, which is yes. Oh, brilliant. Well, I will see you there. Fantastic. I don't know if there are other people on the call from Three Schools programme who are coming along, but we will all get to see each other in person, which is rather exciting and unusual because we normally just see each other online. If no one else has any questions, or if Natasha and Marie, if I mean, I don't know if you've got any final comments that you'd like to make.
mean, the main final point for us is that, as we said in the presentation, that carers of people with mental health conditions, especially when they're going through transitions of care where there is a high risk of for negative outcomes for patients, it's really important to provide to actually support carers at that at those specific points. We haven't done enough. We have focused more on how patients can be supported, which is great. But then we need to do a bit more for carers, because that will improve patient safety. They're the ones who are next to patients, and they're a great resource for the healthcare system as well, because obviously with the workforce crisis, we'll never have enough staff to provide excellent care to patients. But if we've got really engaged and healthy carers, this can make such a big difference to the healthcare system, and save patient lives, of course.
Absolutely. I was going to say, as you were speaking, I was about to say that, you know, it's usually the carers that are providing that backup care during those transition periods when patients are discharged. And, you know, so if they're not in a position to be able to do that for whatever reason, you know, that's another sort of, you know, gap in the system, isn't it?
Exactly.
So absolutely, they need to be supported.
And it was very obvious during the pandemic, of course.
Yeah, absolutely. Well, the pandemic just shone a light in so many dark places, didn't it? I think. Well, thank you both so much. I've really enjoyed that, for not just for personal reasons, helping me out on my bit, but obviously it's something that I'm really interested in. I think it's really important, and I'm sure everyone else has enjoyed it too. I'm going to close the meeting 10 minutes early, and it's quite nice weather, so maybe everyone can grab 10 minutes of fresh air before going into the next meeting or deadline. But I hope everyone has a great day, and thanks for joining us today. And thank you especially to Maria and Natasha for giving their presentation. Thanks very much. Bye, everybody.